A little bit different than some other providers, we don't just look at one specific organ system, we actually look at the whole person. And we try to understand how whatever injury or diagnosis you may have impacts all of you. And those of us who practice physical medicine rehab, like we said, are called physiatrists. Within physiatry, there's a lot of subspecialties that you can have. Mine actually just happens to be spinal cord injury medicine. Thank you. And technical difficulties. Yes. Okay. So it's nice to say what we do and what we do as a whole, but I think what's most important is what can we do for you? So looking at what it is that we specialize in and what our skill sets are, different things that we aim to do, relieve symptoms of pain, bowel bladder dysfunction, where we collaborate very closely with urologists and gastroenterologists, spasticity, abnormal tone or abnormal types of movements, depending on where your spine involvement is. We do a lot of counseling and guidance for sexuality and intimacy. We try to prevent further complications. So we think a lot about your bone health. How is it that your bone health was impacted by your chordoma, by treatments that you may have had? What does that mean in terms of your risk for fractures and how you may move? We worry about spinal instability. There was spine involvement, and it's not something that we're going to surgically address, but how can we protect you from getting into trouble, and how can we help you move in safe ways? Fractures, and when I mean fractures, how do we stop falls for the most part? Preventing fractures in your other limbs, other parts of your body. Pressure injuries, I think all of us try to address this, and I think we're really good about thinking about it when you're in bed. But what about when you're sitting? What about adaptive equipment that you may be using, whether it's a brace, a shower chair? How is that fitting? Is there any area of pressure? Prevention of DVTs. A lot of this has to do with how we're mobilizing, when we're mobilizing. We have a lot of guidance from traumatic spinal cord injuries on use of anticoagulation when it would be appropriate. So we do a lot of discussions with your primary treating team. Ultimately, I think everyone thinks about rehab in terms of enhancing functional independence. And you're right, it's a lot of what we do. Addressing neurological impairments, addressing functional impairments, looking at different types of equipment or bracing needs. How can we help you overcome anything that you're struggling with or that's troublesome for you? We work very closely with your treating team. Oftentimes, we can interpret different symptoms that you're having, help sort through where they're coming from, help guide where symptoms, what the best treatment, not the best treatment may be, but what the targets you might have. We have physiatrists who do electrodiagnostic testing. If you have any type of nerve injury, understanding what type of nerve injury it is, where is it coming from. Cardiovascular and pulmonary management are common places people do not usually think of physiatry, but we can help a lot if you're struggling maintaining blood pressure when you're upright after you've been laying for a long period of time. Or the mechanical piece, so the chest expansion, the cough generating piece of pulmonary, not so much the oxygenation piece, but how can we make sure you're generating a cough? How can we help prevent pulmonary infections for you? How can we help improve your endurance? Similarly, addressing pressure injuries and any type of wounds you have. And ultimately, we do all of these things to help improve quality of life. I think a lot of what we do comes from how we evaluate and how we're taking into account what you're coming with. Everyone is going to ask about your history of present illness, your past medical history. We do as well too, and we try to understand what was life like before your diagnosis. How has that changed for you now? What does that mean? What is your anticipated treatment course going to look like? Medications. You might take medications for pain that might also cause constipation. And if you also had cord involvement, well, that in addition can impact you. So we start to look at these things and try to piece symptoms together. Social history is extremely important for us. What was your life before? What was your role within your family? What was your role within society? Who is your support system? And how can we help you with that now? In addition to that, what did your function look like before your diagnosis? How has that changed? What is it that you can't do that you really want to be doing? In terms of our evaluation, we look at you as a whole, and that's why I love what we do, and it's so important to know we treat the whole person. So the first thing we're going to do is look. What's your posture look like? How are you standing? How are you sitting? Is there something that could trigger us to understand why you might be experiencing symptoms that you are? We're going to check strength, and I always say key and non-key. And most people think, oh, muscle strength is muscle strength. Well, interestingly enough, muscle strength tells us a lot. Your bicep, yes, it helps flex, but what does that mean? If you can flex your arm, your hand now comes to your face. If you could do that, that says a lot about feeding yourself, about your ability to groom yourself. So we're thinking about that, as well as your support muscles. We're going to check your sensation. It's very important to know where you are in space. And it's also, when you have sensory impairments, tells us a lot about different types of pain symptoms that you may have. Any type of range of motion abnormalities, what is that going to mean in terms of your mobility? Your cognition. How are you understanding what's happening? Are you struggling at all? Are you able to guide someone to help with your care? Are you able to use adaptive equipment or really understand the lessons that you're learning in therapy? Addressing fluid, making sure that you're safe when you're getting upright. Assessing your skin, again, not just when you're in bed, but making sure that we're not doing anything that's going to get you into trouble. And watching you walk and seeing how we can help that if it's something that you need. In addition, similar to other providers, we do take a look at your imaging. We kind of work in a little bit of a different direction. We use imaging to confirm. So does your imaging match up with what you're telling us? And is that something that we can address? Is there something else that you brought to the table in addition to the chordoma that might be impacting you? Are there any precautions that we need to take for your activities or any kind of therapies? What is your treatment team? What decisions have they made? What's going to come next for you? Ultimately, what are your goals? And what are your loved ones' goals for you? Those are really important in all parts of what we're doing. So what does this look like? And I think we meant this slide. Sorry, I just wanted to touch on this slide really quickly before we move on to pain. Why do we do all this? And I can't state it enough. It's really because we want to understand your symptoms. We want to understand how they're impacting your function, and we want to help give you a management plan to address those things. So in terms of pain, how are we looking at this? Well, what's important is, where is your pain? What type of pain is it? What can you tell us that might give us where this pain is coming from? We start to think about it in terms of locations of your spine. How is your spine moving? Is there anything else within that area that we have to think about? Does your pain match up with where you have a chordoma or where you've had treatment? We think about nerve roots. So when we think about the nervous system, we have our brain connects to our spinal cord, which connects to nerve roots, which then go out into our arms and our legs. And oftentimes where your pain goes, or if it moves, can tell us a lot about where it's coming from and also how to address it. We'll then look at imaging to see, does this confirm with what you're saying, and what's the best management, and who's the best member of your team to help with this. We collaborate, and that's one of the biggest things about rehab. We're always going to collaborate with your treating team to make sure that we're all on the same page about what we're going to do. We do a lot of education. What's a safe way to move? What's a safe way to carry things? What's a safe way to lift? Making sure that you're not getting yourself into trouble in any way with the activities that you want to and need to be doing. We might recommend bracing. A lot of what we do isn't going to be bracing for immobilization. We're at Memorial, a lot of times if there is a concern about stability, it's surgically addressed as opposed to bracing addressed, but we do a lot in terms of dynamic bracing, correcting posture, trying to help you maintain. There are components of medication management that we do. We do some baseline. There are some physiatrists who specialize in pain who might, do more aggressive pain management or interventions. If not, that might be where we collaborate with anesthesia pain colleagues or also with palliative or supportive care colleagues. We'll coordinate your therapy. Physiatry is way more than evaluation and treat. We will make sure that your therapist has a good script, the things that you should be working on, the precautions that need to be taken, making sure that you have the right type of therapy. Therapy is a big investment. We understand it's a lot of time, so we want to make it worth your investment in that time. We think about your nutrition, the building blocks that you need to make sure we're maintaining muscle, we're maintaining bone. And we may recommend adaptive equipment if we think it's going to help in terms of any kind of pain and how that pain is impacting your function. I want to touch on this because I think a lot of times we don't really understand bracing and when someone recommends bracing. So anytime you hear about a brace, especially when we're talking about the spine, think about the region of the spine that it crosses. So if it's going to cross your thoracic, the mid part of your spine, or the lower part, we're going to call it a cervical lumbar or a TLL. If we add in the sacrum, then it becomes a TLSO. So when you're hearing about those big names or just abbreviations, now you can start to think about what is it that someone's recommending for me? What are they trying to address for me? In terms of mobility impairment, we address it similar. So we're going to think about, what is it that you're telling me? What symptoms do you have? Is it something about your skeletal system that's impacting how you're moving, how you're able to transfer, how you're able to walk? Is it weakness? Where is your weakness? How is that weakness impacting your ability to move your arms and your legs, to get in and out of bed, in and out of a chair, to use adaptive equipment? If you're someone who needs a wheelchair for mobility, are you able to operate it? What's the appropriate type? Sensation, and sensation is a place that a lot of people don't pay a lot of attention to, but we really should. If you don't know where you are in space, it does not matter how strong you are. So if there are things that you're feeling in terms of tingling or numbness or abnormal sensations, be vocal about it, because there are things that we can do and we want to understand how that's impacting you. Recommendations we make in terms of mobility are going to be a lot using therapies. Addressing strength, addressing sensory impairments, addressing balance, addressing your transfers, your walking patterns, any kind of equipment that you need. Our physical therapists are going to address more of the lower extremities and the big muscles in terms of your mobility, whereas occupational therapists focus more on the arms and also on fine movements of the hand. They may also address any kind of cognitive impairments that might be correlating to this. So they work hand in hand together, but it's always important when someone's making this type of recommendation to understand what kind of therapy it is that you need and making sure that you're in the right hands for it. Similarly to bracing, to pain, we may recommend bracing for your extremities to help you compensate for weakness that we don't anticipate is going to improve or something that hasn't improved fully. We may recommend other types of adaptive equipment, canes, walkers. We're always going to make sure it's something functional for you and it's not something that's getting in your way. Wheelchairs. And it's really important to note that if you are going to be a wheelchair user, that your wheelchair needs to fit you. So purchasing one over the internet or just in the pharmacy may not always be the best thing, because you may not fit right in it. It may create other issues for you. You may have more pain sitting in it. So you want one that's going to fit you, that's going to be light enough for you to operate on your own, or if you need a caregiver to help you assist, that they're able to operate. And we might think of other types of equipment for around your home to help you with your independence. I put this up here similar to the spine. Extremities are named based on the joint that they cross. And I know we're not good at saying, we're going to give you an ankle foot orthosis. You're probably going to hear, you need an AFO. But do you really know what that is? So starting to think about, what an AFO is. If we're adding the knee, we'll call it a KAFO. If we add the hip, an HKAFO. So as we continue to work up the leg, we're supporting more and more of your musculature, and we're trying to make sure that you can do more. So we're helping with ankle weakness or knee buckling, or where your hips aren't working so well. Obviously, the more we go up the leg, the more energy it does take for you in terms of moving these. So we're very mindful of, can you use this? Can you use this effectively? Is it too light? Is it too heavy? Is it going to be something that's functional for you? Just to look at some of the adaptive equipment that does exist, it comes in all shapes and forms. And again, what's going to be the most functional for you in your day-to-day. And it's a place for you and your caregivers to be very vocal with us so that we can make sure that we're making the right decision. And in wheelchairs, like I already said, we really want to make sure that it's custom to you, it fits you, and we want to work closely with a wheelchair vendor for you on your behalf, making sure that you have the proper assessment. It's going to work for you in your home and in your community. And in addition to that, we want to help you get it covered. Okay, so a lot of these things are covered. There's a lot of work that goes on the back end, but it's a place that physiatrists can really coordinate with a wheelchair vendor and with your insurance company on behalf to make sure that you're getting what you're needing. So just to look at, and I'm sure you've seen some, but different types of wheelchair, everything from the lightweights to the very custom and powered do exist, and there's a lot of components that can really help. And then just one last one, just some other equipment that you may benefit from around your house, whether it be for standing, for transferring, different types of lifts if you need a little bit more assistance than that. These are all things that we can help coordinate for you. I know you're going to hear from Dr. Brucker a lot about bladder from a different perspective, but we're going to touch on it because it is something that I do touch on quite a bit with my patients, as well as bowel function, intimacy, and sexuality. Where we look at it, particularly for chordoma, and we think a lot about bowel and bladder when we think about sacral, is what is the innervation? Where is that coming from? Are the nerves that go to your bowel and your bladder and your pelvic floor muscles working? Are they working fully? Is there an area where they're struggling? Does your pelvic floor relax so that you could empty your bowel bladder? Does your bowel contract? Does your bladder contract? What is it that's not happening, and how can we help? Also, can you get on and off a toilet or on and off a commode? Do you have the hand function in terms of wiping or any type of adaptive equipment that you may need to make this more functional for you? Those are the questions we're going to ask, in addition to what type of function did you have before your diagnosis? How has it changed during? How well are you emptying? How well are you filling? What part maybe you're struggling with? And so we collaborate very closely with urologists on trying to understand and coming up with a comprehensive plan for you. Things that we're going to address: diet and lifestyle. If you drink a lot of coffee, I promise you will probably go to the bathroom a lot. If you eat a lot of bladder irritants, such as artificial sweeteners, you may have to go more frequently. So we try to educate you on these type of things. If you're someone who drinks nothing all day long and starts drinking all your liquids at 4 o'clock in the afternoon, I promise you're going to go overnight. So we think about timing. We try to make it more effective for you. And I definitely understand it's easier for me not to drink when I have to leave my house, so I drink when I get home. But how can we make that, easier for you so that you can make sure you're drinking throughout the day and not getting into trouble? We do sometimes do some medication management. I said, oftentimes we'll collaborate with urology to make sure that we're picking well, or if they have additional ideas. We do a lot of education on catheterization, adaptive equipment, positioning for catheterization if that's something that you are needing. We coordinate with pelvic floor therapy. And this is something that's often thought about for pregnant women. And they're usually the ones that get referred most. Yes, but there's a lot pelvic floor therapists can do in terms of education on, can you sense that you're full? Can you contract the muscles of your pelvic floor to hold your urine in? Can you relax to let it out? Can we engage your abdominal muscles to help you with emptying? Can we teach you other strategies to help you empty? Can we make sure you're positioned appropriately for emptying? And then we'll talk a lot about, like I said, breathing and different positioning strategies. I put this up here. If you go to the PVA.org, the Paralyzed Veterans Association, there's a consortium for spinal cord injury, and they have a lot of consumer guidelines. A lot of these were initially based in trauma. However, the spinal cord community as a whole has realized that we also have to include spinal cord disorders or the non-traumatic types of spinal cord injuries. And so now the consumer guidelines have expanded further. It's written for you in a way that you can understand what's happening and really give you guidance on the different recommendations that are being made or the different types of questions that you can ask about. Same for bladder, we address bowel. And I always stress bowel because I think more often than not we forget, and we think everything, particularly those who have pain and they take opioids, that everything is opioid-induced constipation, and it is not. And it's so important for us to understand because depending on where your chordoma is, and depending on the type of bowel pattern that you have, the recommendations that we may make for opioid-induced constipation may not be right for you. And they may actually get you into more trouble. So we really want to have a good understanding of what your pattern is, what your pattern was pre-diagnosis. I promise the best we usually try to get you is pre-diagnosis. But can we get you back to that pattern? Can we give you control? What can we understand about your bowel pattern now, about what deficits that you may have, and anything else that might be taken into account? Our goal is always going to be to give you control. You should have control over the time and place of your bowel movements, and it should not take too long, and we do not want you to feel like you have to worry about incontinence. So we might make recommendations about diet, about fiber intake, about fluid intake, really trying to address that to help you with consistency. We may address it with some oral medications to try to help propel stool throughout your colon and promote emptying. We may give you strategies to help relax your muscles in the pelvic floor and of your sphincter to try to push that stool out. And again, we may incorporate our pelvic floor therapists or also our GI colleagues to make sure that we do have a good recommendation for you. I want to touch on sexuality and intimacy. I feel like this is a place where a lot of people are afraid to bring up. Please don't be. Let us know. Let us know if this is something that's important for you and you shouldn't feel like no one understands. We do. We want to know what your concerns are. We want to know if it has to do with body image or changes because of the treatments or your diagnosis. What kind of impairments in mobility do you have in terms of your positioning, in terms of your hand function? in terms of sensation in different areas. What feels good for you now, what doesn't anymore? How is your arousal impacted by all of this? How is the entire sexual response, your orgasm impacted by this? And this is for both men and women. There's a great deal of things that we can actually do to try to help you with this. We can work with you and your partner in terms of your positioning, in terms of exploring different types of arousal or different ways to achieve orgasm. We could address, there's quite a bit of adaptive equipment that does exist for different impairments and positioning. Collaborating with pelvic floor therapists, in addition, collaborating with urologists in terms of medication, women's healthcare specialists, reproductive specialists, if that's something else that's on your mind or you're thinking about. And there's a lot that's out there, if you wanted to explore it first, and there's safe places to explore it, because the internet, I know, is every which way rabbit hole. But there's quite a bit out, particularly on facing disability, which was written by individuals who have different types of spinal cord involvement. There's quite a bit for cancer involvement as well, too. So I do want you to know that there are people who can help. In the world of rehab, it is something that we are trained to try to help you with. And then I just want to leave you with some resources, because I know it's very easy to say when you're in New York, where a lot of academic medical centers and a lot of us do exist. But there's a lot of good resources out there, like I said, within the PDA, of different kind of consumer guidelines, different types of information on equipment that you can have, a lot of different kinds of communities where individuals, I know the Chordoma Foundation is a great one, but if you ever really had any kind of spinal cord related questions. And on the bottom is actually the big Physical Therapy Association. Their website now has a patient section where you can actually click find a therapist and click exactly what you're looking for and where you're looking for it, and they'll generate a list for you to help you find that. So I just want to leave you with this. I'm always available through the Chordoma Foundation for any questions that you may have, but hopefully this is just a little bit of insight into the world of physical medicine and rehab and what we can do for you. Thank you so much.
Thank you everyone for coming and your attention, and thanks for getting the crowd warmed up. Good talk to start. What I think is striking is really how much the two specialties do overlap and sort of blend together, and I think that's going to be a recurring theme that you see throughout this talk and probably the whole day. Managing patients really does become a multidisciplinary process, and I think we feel the same. Here are my disclosures. I'm usually the one in the room that's saying we need more research for patients with neurologic conditions. So I put those disclosures up there proudly saying, look, we need someone that's advocating for patients. And I think more and more that industry will listen and hear the needs, the more we can do. So what I wanted to put up here was a slide that talked about a lot of neurologic conditions. And I think when we are urologists, I usually say I'm just a simple urologist. It's pretty easy the way that I think about things. And hopefully I'll explain that to you. But what's amazing about neurourology and even conditions like chordoma, it can have a very different presentation depending on where a lesion is, depending on when a lesion occurs, what the different treatments are. But lo and behold, if we look at bladder dysfunction, it really is incredibly common for all neurologic conditions, the same way that nerves will affect how our lower extremities move, for example, some of those braces you see, it will affect how the pelvic floor and the bladder work as well. So we're going to talk a little bit about the basic urinary function. This is going to be the Urology 101 for all of you, so you can actually do what I do or think about things the way that I think about things. And then we'll discuss some terminology of incontinence, because I think speaking the same language as the physician and the patient sort of understanding what the physician's saying, the more that everyone knows about how we define incontinence, the better. We'll describe the evaluation so you have a little sense of what I do as a urologist and what patients and family members and care providers may be seeing in the urology type appointment. Talk about the treatments, and then we'll have, I guess, a discussion afterward. So this is sort of a little bit of a technical slide, but it's important to think about what the bladder or the lower urinary tract is meant to do. The lower urinary tract is supposed to store urine, so it should be a reasonable amount of urine that you can hold, and it's supposed to empty sort of on demand when socially appropriate. Those are sort of the basic tenets of what the bladder function is, and as a urologist, I think about this all the time, but often patients are not thinking about this until they start having some dysfunction. or issue. So all you need to know is the bladder and lower urinary tract are broken down into two different sections. There's the filling and storage phase of things, and then there's the emptying phase of things. And if you just break it down into these two very simple categories, you can understand what the dysfunction is that a patient is having. A patient can understand why there are certain things that are not behaving the way they used to behave. And then it's pretty simple anatomically, thank you so much. We have bladder, and that's sort of the same male or female. We have a sphincter or a bladder outlet, slight differences in men and women, and then the urethra. And that's really it. That's all of the basic, science, anatomy, neurophysiology that you need breaks down into these simple sort of situations. So filling occurs, the sphincter or the outlet needs to be closed, the bladder needs to fill up, and then when it's time, socially acceptable, normal duration between micturations or voids, the bladder squeezes, the bladder outlet opens, and the urine comes down. So as we start to think about this, we do get a little bit more scientific and sort of build in some of the tests and things that we do, but you could imagine that the pressure in the bladder is supposed to be nice and low and flat, not doing anything during the filling phase. Then you get the normal desire, socially acceptable in a location where you can void. There's a contraction of the bladder, so it's a muscular contraction, not one that you control, but sort of is subconsciously controlled. And then the bladder empties and the cycle starts again. So when we think about spinal cord tumors, when we think about spinal cord injuries, neurologic conditions that affect the bladder and ultimately affect the nervous system, this is really why things can get abnormal. But suffice it to say that it still boils down to those two basic tenets, which is the bladder is supposed to fill, so the bladder needs to get larger, and the pelvic floor, the outlet needs to contract. And then when it's time to empty, the bladder needs to know how to squeeze, be able to squeeze, and the outlet needs to be open. So let's sort of also look and realize that there are other parts of the nervous system that impact bowel, bladder, and sexual function. This is the functional MRI image of the brain. All those little red spots are areas that light up when someone's deciding to urinate and actually urinate. And so there are quite a few spots that actually are involved. And then there are a bunch of receptors that we have, muscarinic receptors, beta-3 receptors. Not that you need to know all the receptor types, but realize that each one of these receptor types is a potential target for new therapies and new research. So the classification, as I mentioned before, men, women, and children, really it's all the same. The voiding dysfunction issues are either a failure of storage and sort of holding urine or a failure of emptying. And it really boils down to a bladder issue, an outlet issue, or some combination of both. So the terminology of incontinence, we often have patients come in and will mention or complain of or try to sort of bring something up. And these are symptoms. These are things that patients actually are having, people have, and talk to the doctor about it. So it's a morbid phenomenon or departure from normal structure, function, or sensation experience. Here it was for women, but men and women the same, indicative of a health problem. Symptoms are either volunteered or elicited from the individual or maybe be described by the caregiver. So that gives you a sense of, as caregivers for patients with conditions, it's also important to really try to be there to help communicate if, for example, a loved one is not able to communicate on their own. And there are a bunch of conditions and a bunch of things that go into incontinence. So it's not to say that everyone that has the involuntary loss of urine has a neurologic reason to have it, but I did want to sort of pull up at least two or three of these. One of them is the idea of stress incontinence. People here, we mentioned again, physical therapy being very popular for women after pregnancy. You cough, you sneeze, maybe a loved one has mentioned this to you and they leak urine. And that can be an issue with a neurologic condition or chordoma, but that's really not usually the primary driver. There are patients that will have urgency incontinence, so feeling like you need to go to the bathroom and you just don't have time to get to the bathroom and the urine starts coming out before you're in a location where it will be safe and sort of socially acceptable to urinate. There's also a newer condition called disability-associated urinary incontinence, which is the complaint of involuntary loss of urine due to a functional inability to reach the toilet or urinal in time because of a physical impairment or a mental impairment. And again, so you can have a perfectly functioning bladder that's absolutely normal, but if there's a mobility issue or a functional issue to get to the toilet, functionally that's going to result in the same outcome. And then there's also things like insensible incontinence, where a patient says, look, I don't know why I'm leaking, but I needed to start using pads because otherwise I'm wet. And I think what the healthcare providers and the team really are meant to do is to try to elicit a little bit more specifically what's going on. And then we may use, as you had mentioned before, some testing to really drill down and figure out exactly what's going on. But those are some of the terminology. So when we talk about storage symptoms, bladder holding symptoms, if someone pees too frequently, or they have to rush to the bathroom, or they get up a couple of times at night, that's really what we're describing as storage symptoms, how the bladder is holding between the trips to the toilet. And then the voiding symptoms are very varied, but you might sort of think about these things like I can't pee at all, or the urine doesn't come out, or I was told that my bladder is not emptying. And those are all the voiding symptoms, maybe a slow flow, maybe a little bit of an intermittent or hesitant urinary stream. So overactive bladder is a condition that's defined by urgency of urination, accompanied by frequency with or without leakage, and nighttime urination. And overactive bladder is incredibly common. It occurs in about 1 in 6 Americans, men and women about the same. And again, when I'm treating a patient, they have an overactive bladder. We look to see the cause of the overactive bladder. So if a patient has had a therapy or a tumor or a diagnosis or a surgery, that gives me a neurologic answer to define them as saying, hey, you have a neurogenic overactive bladder. That's how we treat it. But a lot of the therapies, a lot of the research, a lot of the things that we do are really there for anyone that's having the symptom of I can't get to the bathroom fast enough. There are patients that will have the urge to go to the bathroom and might leak on the way to the bathroom. And there are patients that might have the urge to urinate. They might be withholding fluids, not drinking fluids, having headaches, dehydration, maybe urinary tract infections because they don't want to drink a lot. And those are, again, there are patients that don't leak, and those are considered OAB dry patients. So urinary incontinence in general, again, regardless of the cause, we know has a major, tremendous impact and negative impact on quality of life. It affects self-esteem, social life, sexual function, work, education. And I think that when we consider incontinence, again, it's not always the primary thing that a patient or a caregiver thinks about or brings up. I'm always the one that's sort of thinking about it, given what I do. But I think hopefully we can empower everyone to realize that these are things that can be impactful. And there's a lot of survey data and questionnaires that go out to patients. And patients with neurologic conditions often will put urinary symptoms right up there with some of the other concerns that they have in terms of sensation, mobility, etc. So in terms of the classification, I mentioned one condition, overactive bladder. I'm not going to give you guys a quiz now to see if you were paying attention, but those were filling in and storage issues. But then there are emptying issues as well. And when we think about emptying problems, I really try to break it down into 2 categories. The first category is this a safety issue or is this a quality of life issue? And both are equally important. But the safety issues are when I'm going to sort of not make a suggestion, but I'm going to really, tell you, look, this is something that you need to do. And without, let's say, addressing a bladder problem that's one of these safety type issues, there may be concerns about kidney damage in the long run. There are other things like annoyances or quality of life things, incontinence. I know they're very important. I just sort of mentioned to you that I think they're important, but those are things where it's going to be a little bit more of a discussion to say, hey, are these treatments and therapies sort of making me better? What do we want to pursue? The causes of the emptying problems are either the bladder is not squeezing, so there's a muscular issue or an innervation or a nerve signal to the bladder issue. The sphincter is not relaxing, or it can be a combination of both. So I want to just describe the evaluation in the next couple of minutes, and you'll see in medicine and any specialty that comes up here to give you guys a talk or a lecture you hear, we'll talk about some of the basic history and physical exam. But the things that we want to also focus in on about your urination or incontinence is really understanding how it's impacting you, when is it happening, what are you doing now to manage this on your own. We do want a neurologic history. Where are you in your disease course or treatment course? We want to understand things like bowel pattern and bowel habits. Physical examination, I'm not a neurologist. I don't claim to be a neurologist, but I really do need to understand, can you contract your pelvic floor muscle? Do you have lower extremity weakness? Are there other signs or symptoms that might impact the therapies that we ultimately end up choosing, or things that you might not be telling me that I need to sort of dig a little deeper to find out. And then there are some basic lab tests to check kidney function and urine testing to make sure no infections or other issues. But I think each patient is different, so this is the basic evaluation, but we obviously tailor it. And as I mentioned, sort of understanding, especially for a condition that can affect the spinal cord, we really want to get an idea as to where the lesion may be or where the treatment was, so I have a better understanding of what certain patterns I can expect to see. There are questionnaires that are given to patients to assess incontinence, to assess sort of issues. This was one we did a little bit of work validating in an MS population, but again, a lot of these are for all neurologic conditions. But then we also have something called a Bladder Diary, and this is an incredibly powerful tool. This is something that costs you nothing to do. You can do at home. You get a piece of paper and you write down how much you're drinking, and then on the other side, write down how much you're urinating. We can give you a little hat or a little jug to pee into or a commode that you can utilize. But this sort of gives you a sense as to, are you drinking too much for the condition that you have? Or are you drinking adequately, but your urinary timing is really such where you're peeing quite frequently? And diaries are incredibly useful. There are some times when more testing is needed, and this is something that I think we used to over-test patients, and now we sort of try to be a little bit more conscious and test appropriately. The image on the top is an ultrasound, a nice non-invasive way of checking how your kidney may be functioning in case there is an issue or one of these safety problems where the bladder may not be emptying. There's a scope or a little camera on the next image on the bottom. Not everyone needs to have a cystoscopy, but this is a tool that a urologist has, just like a cardiologist has a stethoscope. You see a CAT scan image just next to that to look for other reasons why someone might be having pain or a kidney stone. Just because you have a diagnosis of chordoma does not mean that you can't have a kidney stone. And I think that's something that's very important when you're considering patients. We sometimes find on physical exam prolapse, or a woman has an issue where her uterus is falling out, having nothing to do with the condition that she's being treated for, but you don't want to put patients into a little box and say, hey, this is how they're going to behave because they have this condition. We need to sort of consider all of the aspects of their health and health care. And then the image on the top is a test called a Urodynamic test, which is a comprehensive functional test to see how the bladder is working. So in the next couple of minutes, I do want to talk about treatment, but you heard already that physiatrists are talking about this, your internists may be talking about this, neurologists, neurosurgeons, but what's sort of the appropriate amount of fluid to drink? What should you be drinking? What should you be doing? We know that caffeine, if you're peeing frequently, as was mentioned, is a problem. Well, can't I just have that one cup of coffee in the morning, Dr. Brucker? Absolutely. I don't mean to tell you you can't, but if you have that second or third cup, and then come in saying, hey, I'm really having a lot of frequency of urination, I can give you medications, but you can also take ownership and sort of help yourself. In terms of sort of the other things that we know, if you drink a lot of fluid, and let's say you're catheterizing a way to empty the bladder, it may take a lot more time for you to toilet than someone that's not catheterizing. But if you're drinking a lot, needing to catheterize a lot, then it becomes a little bit more of an issue. So that's sort of considering the specific case and making recommendations. But again, we are in a society that makes coffee drinking fun, and I understand people have coffee. You know what? You can have a decaf instead, and it may have less caffeine and may irritate the bladder a little less. It's also great to see that others aside from me are concerned about constipation, and there is a huge link between bowel and bladder dysfunction. There are patients that have retention issues, and when we fix their constipation, their retention issues get better. Sometimes maybe it is drug-induced, maybe it's neurologically induced, treatment-induced. Fiber is usually the key. There are patients with spinal cord tumors and injuries and other neurologic conditions that may need to use enemas to empty or evacuate their bowel. They may need to use digital manipulation to get stool out because, again, we don't want to have another condition or another process that we have to deal with when we're trying to fix the urinary symptom. And gastroenterologists, and even more specifically, functional gastroenterologists, those that are sort of interested in how neurologic conditions can affect the bowel, are actually harder to find, but a very useful resource. And what this picture is that you saw in both of our slide decks is the Bristol Stool. Again, fairly easy at home to sort of Google Bristol Stool and see the different types of stool and sort of do a test on yourself by looking at the picture and looking in the toilet bowl and saying, hey, do these things two match up? Where do I fall on the scale? and we really want to be more in the normal range rather than either too hard or too soft. Physical therapy and occupational therapy, as you're catching on the theme of the session, are very, very common, and physical therapists can help patients with, for example, chordoma or urinary and bladder issues. Not every patient's going to respond to physical therapy the same, but it is important. If I know that your pelvic floor muscles are contracting, there's no reason you can't do physical therapy, and we really try to encourage it because the less medication I need to prescribe, the happier you are and the happier I am. There are adaptive tools as well. Some patients have difficulty, for example, catheterizing, or as we were talking about, let's say even difficulty transferring if someone is not able to transfer on their own. If the normal time to urinate is, let's say, 2 minutes that someone has, but the transferring process takes 8 minutes, now we're getting back to that functional incontinence that patients can have. Biochem 101, cells talk to each other. So talking about how we sort of use medications, when we stimulate receptors, it gives the cells a little bit of a different sort of chemical milieu, and then we'll turn on or turn off other aspects or other functions. So I can use drugs to try to block receptors or turn on receptors. And not to go into all of the details, but this image you saw before, those little receptors on the side will actually be targets for drug therapy. So if someone's having a difficult time where their bladder is irritable or overactive, I can use different classes of medications to calm the bladder down. The same way if a patient has difficulty emptying, my options may be a little bit more limited, but there are a few pharmacotherapies we can use. What's exciting sort of in terms of newer technologies is a whole slew of what we call advanced therapies for patients that are having this urgency incontinence or overactive bladder incontinence. Botox is up there, not for wrinkles or for cosmetic purposes. It's actually FDA approved for patients that have neurologic induced detrusor overactivity or incontinence because of a neurologic condition. This other device on the bottom is an acupuncture type therapy. Again, I don't have FDA clearance to say, hey, this works in a neurologic patient, but we do studies and we see patients do well. So again, some urologists or general practitioners may not offer all these therapies, but finding a specialist, someone that has an interest in neurologic conditions, will again be able to have a discussion with you and explain that this could be used to decrease the number of times you're going to the bathroom in a nice, non-invasive way. We also have the option of an implantable device on the top image on the left called Neuromodulation. And again, there have been some advances now. Finally, we have Mri Compatible Devices. And it really was I think, unfair that we couldn't use these devices in the past because patients that have neurologic conditions or tumors or oncologic conditions need MRIs from time to time. And if you can't get an MRI, then the therapy is not really an option. Bladder emptying, and this is, again, maybe a different sort of side of that equation, but if the bladder is not emptying, there are not a lot of medications we use. It's more of a physical thing that we need to facilitate. So there's intermittent catheterization. That's these little catheters over here. They come in different shapes and sizes. They're easy to conceal. You can put them in a purse or in a backpack. It looks smaller than a lipstick container in some cases. There are some that are more involved. Some patients don't have the dexterity, the ability because of mobility issues to intermittently catheterize or drain their bladder, and there are bladder catheters that can be inserted surgically into the bladder in order to facilitate or sort of make quality of life better. There are definitely other surgeries that can be done in more extreme cases. So again, it is a lot that sort of goes into this decision-making process, but if you simplify it and say, look, it's a bladder storage issue or bladder emptying issue, then we can come up with options. This little device that has a flash through it here is called a condom catheter that male patients can use. The reason I sort of X'd it out is it doesn't facilitate bladder emptying. It's really a therapy that can be used and is effective to use in patients that have the storage issue. But if your bladder is not emptying and you just put a little condom on the outside of the phallus that goes into a bag, it's not going to help the bladder empty. It's still a tool. It's still a way of managing incontinence, so we use them, but these are sort of a few of the different flavors of ways that we can empty the bladder. And as I mentioned sort of before, it is multidisciplinary. You can't see all of the little things here, but we have things like comorbid health conditions, psychosocial lifestyle issues, mobility, cognitive issues, and the things that I usually am a little bit easier at helping in the urology space or the neurourology space are things like sphincter issues or outlet issues, bladder problems, it's underactive, it's overactive, and then ultimately infections, which can occur as well. So in conclusion, bladder problems are extremely common, regardless of what the treatment modalities, the neurologic condition, but chordoma is no different. Now you can think of things like I think of things. I don't know if that scares you at all, but that's the basics of how we think about urology. And you might not know all of the different drugs I'm going to choose, but I think if you have at least the understanding of how we break things into these categories, it will help you in the discussion. Bring up concerns if they're bothering you. These do have a big impact on quality of life. It might not be priority number one, but I think that it is something that we do need to continue to ask patients about. I certainly ask, but you're in other doctors' offices and they may not bring this up as the first sort of thought or the first option. Set goals. I think that's very important. You should be forthright with your doctor or urologist and say, hey, this is what I'm looking to achieve. This is what my goal is. It's okay for goals to change. It's okay to get information and data and have a healthcare professional conversation and say, hey, talk to my loved ones and the rest of my team. But I think it's important and really stressing the multidisciplinary approach, which is often needed. Thanks.
Yeah. Does anybody have any questions for the question? Okay, I'm not a psychologist clarification, but I'm just wondering if you together have any advice on the difference between perioperative urinary retention and kind of giving patients, and I'm not sure if patients have experienced this, but postoperatively there's a common occurrence of sort of urinary retention. When and how to kind of transition patients to a urologist or a physiatrist, and how to counsel people that this isn't going to be forever versus this could be forever. Because it's a very difficult thing to ask.
Yeah, I can take it if you want. So I think as a surgeon, and really as any healthcare provider, setting expectations is hugely important, and sort of explaining to patients there are different aspects. And there are things you read on the internet that talk about retention or not being able to pee, and then there are things that occur that really have nothing to do with, let's say, a therapy or a surgery. In some ways, if there's suspicion or concern, I think evaluating preoperatively or having a discussion with the urologist preoperatively is probably a good idea. I never mind seeing patients before surgery, even if there's nothing for me to do. I do it all the time for patients that are having hysterectomy for other issues, patients that are having spine surgeries for non-chordoma sort of issues. But I'll sit down and I'll say, look, this is sort of the basics. I'll give them a piece of this lecture that I gave all of you today in terms of how we think about it, and so that they know who I am. And then post-operatively, if they're having an issue with retention, it's easy enough for me to give my recommendations. I now have a relationship with the patient, and then they sort of are a little less stressed out about it, and they know what the follow-up will be. The follow-up and sort of, is this a 6-day retention or a 6-month or that's a little harder. There's no way of really predicting. We do things like look for a return of bulbar cavernosus, reflexes. So I sometimes will examine patients in the clinic and try to give them a little inkling whether it's a spinal shock type issue or it's a more of a compressive problem, or is it going to be long-term? And then urodynamics are one of those tests that we use, where we can sort of say, hey, where are you now? And if a patient's bladder is not working at 6 weeks or even 3 months, I tell them, look, I don't know whether this is going to return or not, but let's sort of deal with what we can now. And that's where I'm very quick to introduce things like intermittent catheterization, because then at least the patient realizes that they're going to maybe start voiding again on their own, and they're not going to have a catheter constantly in. Or if they don't, then at least it's sort of a more sustainable option. I don't know if you guys have done pre-operative counseling.
Yeah, so I'll actually, I meet with a lot of patients as well too who have the diagnosis of chordoma, who haven't had their surgery yet, or they're having radiation and it's unknown if they'll have surgery. Just to introduce what type of neuroimpairments may happen, talk about things that they're currently experiencing, things that may happen during their course of treatment. And so we'll talk not only about bowel and bladder and sexual functioning, we'll talk about mobility, we'll talk about potential sources for pain, just to give guidance. And then we'll follow during the treatment course, and as things are coming up, we'll help address them as well too. But it's an opportunity to ask those questions of what if this happens or what if that happens, and kind of to provide some reassurance that there's a team that's going to help with this, and these are the things that we could do to help with it. In addition to that, a lot of times after surgery, patients will actually go to rehab units. We're very in tune to bowel and bladder emptying. We'll try to coordinate therapies around emptying. We're a lot of times we're the ones who actually do voiding trials because patients will leave with a Foley and it comes to us. And we're very mindful about how we're doing trial avoids and not just taking it out, reinserting it, but really getting the opportunity, addressing with intermittent cath if that's what needs to be, and really monitoring what the neuro status is and trying to understand. A lot of our patterns for neuro recovery come from trauma. And so I always try to say when someone asks me, you know, if this was a traumatic spinal cord injury, this is what this may look like 3 months from now, 6 months from now, a year or two from now. Because of the nature of chordoma and how things may change, it's a little bit more of a moving target. But if we're looking for here and now, these are things that we may be able to expect. And then just rehabbing that conversation should things change. But I think getting us involved early and having those conversations so people know what to expect or know that there's someone there who can help them is just helpful.
Now, I think most of us here have significant nerve loss. I know myself, it's 2, 2, 4, 5. The first question is, and from my experience, some people have to self-test, and other people can't stop going. First is like, why is that? And then second, on the can't stop going, do you have, and I've been seeing urologists for 10 years. Do you have any suggestions what to do about that to make it more manageable? So like if I come here and I have to take a whole suitcase full of products.
Yeah. So the reason I sort of chuckled when you said some can't go and some go too much, a neurologist actually, one of the smartest neurologists I know, was trying to explain to a medical student about why that was. And he sent me probably like a 4-page email that had all the different, nerves and how things function. And I kept reading it, going back and looking at the literature. And I think what I surmised is we don't really know. And I think it's actually for sacral and lower down, all of the nerves are down there, right? So it's a little bit more challenging because if it affects the nerves, they're not labeled this, but A and B versus 1 and 2, it may have one effect or a different effect, and disease may change based on a disease progression or effective radiation or effective surgery and postoperatively. So I think that's where I simplify it and say, are you having a problem with emptying or are you having a storage problem? And if you have frequent urination, but your bladder is empty, then you have a storage problem. And so often the first few steps will be those medical therapies, the pills and sort of things like PT. If that's not happening or helping enough, then we start to think about things like Botox in the bladder or neuromodulation.
What's I've had the Botox. I wrote that down. What's neuromodulation?
So I mention it with caution again, because of the MRI issue, we don't have a lot of experience for a condition like chordoma and its use. But what neuromodulation is if you think about needing to pee and you tighten up your pelvic floor muscle and it prevents you from having to go to the bathroom, you can then make it to the toilet and relax. Imagine if there was a little way to sort of splice a wire into that neural pathway so that constantly a little battery and computer chip is sending a signal to your brain to say, okay, not a good time to pee, not a good time to pee. The caution, I think, depending on the tumor, the treatment, some nerve roots and some sort of effect of that area may be affected. So if that signaling pathway is totally not working, it may be very hard to know whether this therapy would work. The nice thing about it is we test it. So there's a test that you do with a way of sort of putting the nerve or the wire on, seeing if the signal works or doesn't work. Doesn't always predict perfectly, but can give us an idea. The bigger issue now is really just not having FDA clearance to use it in neurologic patients So there's a lot of research and a lot of interest in it. So sometimes there are some coverage issues for that, and which is why advocacy groups and sort of, patient sort of groups can be really helpful to partner with us and say, hey, let's plead to get coverage for some of these therapies.
Can I add, I had the opportunity to interview Dr. Keel from Northwestern, and the Chordoma Foundation has a lot of great resources on their website for getting into the specifics of different treatments. So Andrea Locke can put you in touch with that if you're interested. And this is probably a year and a half ago, so maybe technology has changed, but she did say for that it almost always connects to the nerve root at S3, and some chordoma patients don't have S3. So therefore it's not an option. So again,
yeah, no, I mean, so the target is S3. It might work still in S4 or S2. There are pudendal nerve stimulators. Again, I would agree that if you said to me, look, are you very enthusiastic or not, usually knowing where a patient's disease is and what sort of the treatments they had and what other functions they have, I might be able to say, hey, I'm hopeful or not so hopeful it'll work. But at a certain point, you do need to make a decision to say, hey, let's try it, let's see. And sometimes you get surprised. And again, if the answer is trying something versus having to lug around the suitcase with the diaper, you might say, you know what, it's worth a try. If it's safe, if it's medically appropriate. And again, things like Botox, we do use Botox, and you can use higher doses of Botox. I don't mean to say that, again, depending on everyone's experience, if you use enough Botox, then you're going to maybe have the issue with the bladder emptying. And so that's where I sort of simplified again, it's either the storage issue or the emptying issue. Right now you're describing the storage issue. These are the therapies we can use. And then if that's not working, then there's another option. And those surgical options I mentioned, they sound invasive and sound sort of a little bit more involved. But if it's affecting quality of life, there are times when some of these surgeries in a couple of days in the hospital can have a tremendous positive impact. And that's where it's what's the goal, and then sort of, what the other functions or dysfunctions are, and come up with a treatment plan.
And just to add, sorry, that's also why I know I do it, and I'm sure as well, we ask what happened before. Because what you bring to the table before your diagnosis is just as important as your diagnosis. And so if you had any bowel or bladder impairments previously, they may change, they may get worse, they weirdly enough may get better because of the diagnosis and because of the nerves that may be involved. So it's really important to know why in the beginning, and so sometimes it's the why before that tells us why people are so different. The other thing I can say is that spinal cord is a little funny in terms of where things come off of. And so there's two sets of nerves that have to do with innervating the bowel and the bladder. And even though they carry the same, 3, 4, and 5, they actually are from opposite parts of the spinal cord. So some people lose both. Some people only lose part. Some people only lose one side. And so it's all about what was actually involved that tells us another reason why so many people are so different. And the last piece just to add is it's also where medications come from and why it's so important for us to know all the medications that you're taking, because there may be side effects of the medications that you have that not only cause bowel constipation, but cause bladder constipation as well too, or urinary retention. And so if that's where it's coming from, then those are pieces that we need to be addressing as well too.
I just wanted to mention a couple, I'll call them comfort things. Something, my husband had lumbar L3, 4, and 5, and dealing with the catheterizing, that type of thing. And over a course of years, he had real major surgery 3 different times, went through the total rehab from working way up to his wheelchair. One of the things is when he was first told about the catheterizing, there was a mental hurdle to get over with that, but they included me along while the training and that was going on. And I think that was considerate of them, and they knew that would also help my husband. And I'll be honest, he did what they told him he had to do while I was in the hospital. He got home, he said, I'm done, you do it. And so I learned. I did. That was not worth the battle.
What we do for love.
But yeah, right. I'll tell you, that and I said I've never had my hands in so much DM only, I call it something else in my life. But in conjunction with that, you mentioned your suitcase and stuff. When, my husband's name's Marty, when he was discharged from that, they gave him a backpack that was camel. And it just was a little bit more manly and okay to carry that thing around that way. And people didn't know that we had a urinal in there, and we had pads, and we had catheters and all that stuff. And then we always were able, especially at the hospital, we found the family-friendly restrooms where the both of us could go, whatever he needed. Then the other thing, and at this point, I think it was after his second surgery that I'm not with the ureter, and that it's, in my terminology, I'm going to say it must have kinked or something, because he had stents put in, and I didn't hear anybody mention stents. But that's just something that, again, was very helpful at that time. They tested him before they, whatever that machine is that shows you you're in the bladder, and it was full, that's why it was coming out. And then the stents, and I think they had to change every 6 months to go back in the hospital for a day thing. And that, but that's, I'm just sharing that because it's personal experience, and you don't know what people are thinking.
And thank you for sharing it. I think that really that mental hurdle that you mentioned is very, very real. And it's sometimes, for some reason, catheters sort of, a lot of men and women will say, no, never. The idea of using a cane to walk or a walker, people have seen that. It's a little bit more public. They know what it is. But some people have never heard of or seen a catheter, and I don't know if that's why, or if it has to do because it's a little bit more of an intimate area that they're catheterizing. But I think a lot of what we do is talk about and sort of try to get, willing family members and caregivers. So I think it was tremendously important that they did get you involved. And honestly, it may not have happened if you weren't involved. In terms of ureters and stents, so I'm not exactly sure, may have been two different issues, but stents are for the kidney and to help it drain into the bladder. Sometimes when we're not sure if the issue is the bladder itself causing the kidney problem, or if it's a kidney problem in and of itself, let's say from radiation strictures, or if there was metastatic something, disease compressing, or for some other reason, stents can be used. So not necessarily as part of the continence and incontinence or the frequent urination or emptying, but yes, as urologists, we use stents, and that can be appropriate. I'd say a little less common in the neuro population, but yes, it can occur.
I will admit, I'm also usually the one who hears, I'm not going to be doing this. I guess my surgeon, I guess my oncologist, I guess everyone else, and then I come in and I'm like, oh, I hear you do this, this, and this. Oh, no, I didn't do that. And that's okay, but it's important, and that's where relationship building is so important, and why it's so important for us to know who your support system is, because we want everyone to be involved at your level of comfort. But at the end of the day, the decisions that we need to make together, because you're going to leave, and this is your life. We can make the recommendations, but then we go home in a little bit different life. So it's always about what's going to work best for you. And in part, a lot of what I do in collaborating with the rest of the team is I'm the one who'll tell them what you're willing to do and not do. And I let them get mad at me for it, and that's fine. But it's in part our job to work together to make sure it's something that you're comfortable with and that you can do. And a lot of the education, a lot of things that we'll do if it's a CAP recommendation, sometimes we'll try to skirt the issue a little bit and see what else we could do first, in giving you other attempts at things you could do first, but then, working with you about how is this doable, what might you need to do it for yourself, where will you be able to do this, how can you position for it, and, I always say it's easier for a man than trying to get a woman even to wrap her head around it, because the anatomy is so different, and so it becomes more education and different types of education. But if I know what the plan is and I know what you're comfortable with, then I can work with your team, but I can also work with you for what you're willing and comfortable with. But that's why it's so important to speak up and to share experiences, and to share experiences with us, because that's also how we learn.
And also I would add, trying to understand what the barrier is hugely helpful. And some patients will tell you, but other patient family members will tell you, or another doctor that tells you, because there are times when I had a patient, and her issue was because of the lower extremity weakness, she couldn't stand in a position to catheterize. And then all of a sudden the light bulb went off and said, okay, well, we need to come up with a better way for you to catheterize. So whether it's assistive technology or we ended up making it so she could catheterize through her belly button into her bladder with a small little, tube that we made from her intestine. So meaning, again, not saying that that's appropriate for everyone, but if you have a problem and there's sort of a barrier and we identify the barrier, some patients, again, women use smaller catheters and that's just what gets given to them. And then a woman says, look, I have to do it laying down. I can't see, my belly's a little bit bigger. And then all of a sudden you realize, why not use the bigger catheter, the longer one? And then all of a sudden what was a barrier is not a barrier anymore. So I think that if you can identify really where the hang up is, and look, maybe it's your husband's stubborn, I don't know, right? And that's okay too, but why? And sort of what is he dealing with? And then we realize, gosh, he's depressed about what's going on, and then sort of getting the rest of his team or the psychiatrist to talk to him. And so it's not that we can fix everything, but the more we know and the whys and the why nots, I think the easier it is as physicians to try to assist.
And so I think it goes back to the first question of when people know up front what may happen, gives you longer time to wrap your head around it than as things are coming up. It's a lot to wrap your head around, and it's a constantly changing thing to wrap your head around. And we understand that, and so the longer time that we can have this and help you, and in the world of cancer rehab, we talk about different phases, and so there's this idea of preventative. How can we prevent the things that we know are going to happen for you? How can we minimize the impact? The restorative, how can we bring you back to where you were before? The supportive, how can we help you where you are now? And within all of that, it's always the now and the next step moving forward. And so we're always thinking about that. And sometimes what we do changes a lot, and sometimes what our colleagues do changes a lot, but it's always the here, the where are we going, and the where might we end up, and making sure that we're constantly looking at that so that you don't ever feel like you only see me here and now and you're not thinking about anything else. But we always want to make sure that you're prepared for what may happen, or as things change, we want to know so that we can revisit what we're doing, because what we might have recommended yesterday might not be okay next week because something may be different, and we want to be on the same page, and we want the whole team to be on the same page about it, because sometimes that's actually the biggest barrier. Things have changed. You're still doing what you were doing last month, and now it's not working. And then getting to buy into the next thing because there's that fear that it's not going to work. And we understand that, but if we can think about it and we can kind of partner together in it, sometimes that also helps.
Is there another question?
I have maybe a more generic, I'm just going to take this off because a lot of people can't hear me. A more generic question about physiatry in general. So I guess I first heard about physiatrists like maybe 3 years ago or so, and it's been very sporadic off and on. And I kind of always separately knew that physical therapists were guided by some kind of doctor, but it's never been clear what that doctor is. So has that always been physiatrists? And then your talk very much focused on chordoma, and so therefore like movement and bladder and that kind of stuff. But I was wondering if you could give an overall sense of everything that you do, I guess.
Absolutely. So we're a really well kept secret. Physiatry has actually been around since World War I. So we've been around through the World Wars, through polio, through quite a lot. Historically, we were physical medicine doctors and rehabilitation doctors, and then the powers that be decided we should be one. Not everyone thinks about us up front. Oftentimes we're thought about for certain diagnoses that kind of funnel through very quickly. I think everyone thinks stroke in terms of the big one. But what do we do? So we're kind of jack of all trades. So we have a really good sense of the musculoskeletal system, how the musculoskeletal system works. So we could do everything from pain to sports-related injuries. We understand the neurological system, both kind of brain, spinal cord, and the peripheral nerve. So we help individuals who might have a brain injury or a stroke, traumatic spinal cord injuries, multiple sclerosis, all those types of neurological diagnoses, peripheral neuropathies. So we address any impairments to the musculoskeletal and neurological systems that come up related to a given injury, a given disorder, a given treatment. And we basically, our goal is to understand what it is that you're experiencing, why are you experiencing it, how does it impact your day-to-day, and then either one, how can we restore your function back to what it was before your injury, how can we help you support with any kind of impairments that you may have now, and that's kind of key where bracing and different equipment come from. How can we help you plan for your next step? So we're kind of experts at the musculoskeletal and neurological systems. And really our whole point is to see how one given diagnosis impacts you as a whole person, and what kind of needs that you do have. We do work with physical and occupational therapists, and a lot of times people assume that's what we are. But where we come into play is they'll carry out the therapies, but we help guide. So we'll tell the therapist what the diagnosis is, what specific things that we want them to work on, what precautions that they should take into account so that they're keeping you safe while they're doing it. And then as things come up, we work with them. So say, you're doing therapy and now you're developing pain, and that's your barrier to therapy. Your therapist will come back to us, let us know what you're experiencing. We work with you to address that pain piece so that you can continue with your therapy. We also try to point you in the right direction for what type of therapy would be most beneficial to you, because we have a good understanding of all of them. So we're the kind of, basically the quarterback for all of it. And we make sure that all the key players who need to be there are there, and that you're getting the right treatments that you need from those perspectives. But we're a pretty good team.
And the segue to that, your last slide that you were showing, I think the last, I couldn't see it, was how to contact physical therapists. Are they in that site? If you could give us that.
So yeah, so it's actually APTA.org, the American Physical Therapy Association.
Okay.
If you go onto their website, there is Find a Therapist or Find a PT. If you click on that, what's nice about it is there's a drop-down menu of what type of therapist you're looking for. Someone who does sports injuries, someone who does pelvic floor, someone who does cancer. And you can click on that, you can enter your zip code, tell them how far you're willing to drive, and they'll actually tell you all the therapists that are credentialed through the APTA. So there might be therapists who aren't on there, but it's a nice way to get some information on it. One big thing I always say, because I get asked a lot because people come to see me and they live all over, is how do I find someone, whether it be a physiatrist like me that they can check in with more frequently at home, or a therapist who's close to them. And the best piece of advice I always give is find your closest academic medical center where you live. Ask them, because you may not have to go to that specific location, but if it's any place that's academic and has an inpatient rehab unit, that means that they discharge people to the community in that area, and they're going to know who's there. They may have satellites in areas that are closer to you, but they'll know, when we discharge patients or when we see patients here, this is who we refer to. And so then you can kind of have a little bit more insight about who's in the area. The other nice part is, none of our worlds are very big. Yeah. We all know people everywhere. And so we ask our friends who may live in a different state, who do you refer to, who do you recommend, and then we can always come back.
And as a prescriber of a lot of physical therapy and a sender to physiatry, and it may be a little bit New York centric, there are different flavors as well, and there are different expertise. So if someone, let's say, decides to go for pelvic floor physical therapy at home, and then, they send me a picture, with a thumbs up, but it's like all guys working on torn rotator cuffs, but the issue is an incontinence issue in a woman. I'm not knocking it, but they may not be the best person. And then there's a little bit of frustration that comes because they're paying, and it's, again, you'd hope that the physical therapist or the physiatrist says, hey, not my area of expertise. In other areas, you might not have an option, and something's better than nothing. But I think I would always encourage patients to say, tell them this is what you're seeing them for, and these are the things that Dr. Brucker wanted you to work on, and here's his number, call him, because it takes about 2 minutes for me to explain what's going on and say yay or nay, versus you might spend 12 weeks in therapy and they never once, let's say for pelvic floor, undressed you and examined you internally. It's not the right person. So that's, I think, where physiatrists do that a lot in terms of helping guide that. But if you're not seeing a physiatrist, but you know physical therapy is something you need, then hopefully whoever's suggesting it can do a little bit of that recon for you as well.
And it's true, and you raise a good point. I talk to therapists from all over, all the time. I never say I'm not gonna do it. So if I were to give you a script and send you, your therapist can always reach out. And I think any of us who write the prescription want your therapist to communicate. And more so during your course, we actually want updates of what they're working on. And I'm very honest, I've received updates from therapists and I call them up and say, this is not it. Like, you're missing the target. We need to be working on something different. Or I'll reach out to a therapist and say, listen, we just found out that there's progression of disease or there's going to be a new treatment that's in place. So what we were working on is not okay anymore. And we need to work on this instead. And I'm going to send you an updated prescription, but I want you to know. So it's really important, that the communication piece, and you should never worry that, say you came to New York for, your recommendations, but you were going home. Don't ever feel like just because you went home that you're cut off now. You're not. And any one of us is more than happy to try to support or help or provide guidance. I know I get emails from the Chordoma Foundation quite a bit asking me who I would recommend in an area or how can I point a patient in the right direction. And I think any of us are happy to try to help with that too.
Well, thank you so much.
Thank you.
Next session starts in 10 minutes.